Our next speaker is Dr. Alan Pearce from La Trobe University. Thank you.
Hi. Thanks, Chris. Thank you for letting me come and have a chat to you today about my research, which is a bit of a journey. So I guess that's what the presentation will be taking on. I'm certainly not a clinician, so I'll be probably giving a little bit more of a song and a dance with my presentations. But I really want to talk about the research that I've been doing in what we call neuromodulation, which is stimulating the brain and looking at the effect of brain stimulation on outcomes for MdDs in particular. Mainly what I'll be talking about is my area of research, which is looking at brain stimulation, or the technical term neuromodulation, and really talking about two studies in particular over the last couple of years that I've been involved with in terms of looking at MdDs. So just very quickly to go back through the literature, obviously other presenters today have done a magnificent job in talking about MdDs, but from a scientific perspective, really, whilst MdDs has been first recorded in the for nearly 2 centuries now, in terms of sailors coming off extended trips with what they call quote-unquote sea legs, and feeling like they're still on the boat when they come onto dry land. Really, the modern scientific study of MdDs has only been in existence for probably 30 years, and even then, in the last 10 years, we're seeing that MdDs is now having emerging research, scientific study in particular, and I think Char has to be given credit for leading the research in that particular domain. I guess it's also important now that there is a much more serious approach being taken towards understanding MdDs. We are moving beyond the case reports and observational studies to more empirical research, looking at potential interventions, and I guess that's where I really want to be sort of focusing my presentation today. In particular, I guess for me, it's been about looking at trying to reduce the symptoms. As you know, there's a number of a constellation of symptoms that people may have some or others. It's very difficult to have a standardized symptom response, and so we are trying to look at this from a very generic perspective, particularly in the neuromodulation space. So I think what we'll find is that neuromodulation will be working in with a multimodality approach for treating symptoms of MdDs. But as you can see, there's a whole range of different symptoms that Luke has already talked about. So from my perspective, the potential of using brain stimulation has emerged from the pioneering studies of Char, in particular with her imaging, neuroimaging, using magnetic resonance imaging, or sorry, I should say functional magnetic resonance imaging, which is what she has shown correlating to the general symptoms that you find with people with MdDs. In particular, her work has shown that there is increased areas of activity in the brain, in particular in the what they call the entorhinal cortex, where there has been increased activity in the brain of people of MdDs as opposed to controls, but also what Char has also found is that there's been decreased activity in the left prefrontal area of the brain as well. So we see excitation areas, excessive excitation areas, but also excessive inhibition areas as well. And so in terms of the connections between the frontal area and this particular cortex, entorhinal cortex, Char has really sort of used that as the basis and the rationale for
potentially using brain stimulation to, I guess, see if alterations of these areas can come with symptom relief. So the work that Yun-Hee Cha has been doing from about 2010 to about 2012 really was when I first heard of MdDs, and as you can see here, Glenda on the right actually contacted me serendipitously in 2012, and Glenda had actually asked me if I'd ever heard of MdDs, and obviously my response was no, I hadn't. And before we go any further, I really needed to read up and understand what we knew about MdDs at that particular time. But Glenda had also mentioned that Yun-Hee Cha had used magnetic stimulation and in a neuromodulation sense and had been getting some positive results. And I really needed to understand that a little bit more. Now, Glenda was ringing on behalf of her mother, Faye, who has MdDs for nearly 15 years at the time. Very stoic woman, but obviously after a chronic bout of MdDs over more than a decade, obviously this was impacting on Faye's psychological health as well as trying to deal with the constant rocking symptoms. And so I guess, with Faye and Glenda, at the time that we had met, I hadn't had the data. I wasn't able to see the data from Yun-Hee Cha's brain stimulation study. It hadn't yet been released, and so we were unsure about what parameters Yun-Hee Cha had done, and so it was very difficult for me to be able to just provide brain stimulation in an ad hoc capacity. So in terms of starting, being at a starting point, I had discussed the issue of brain stimulation with Faye and Glenda, and while we were waiting for Yun-Hee Cha's study to come out, I really wanted to, get them to understand what brain stimulation is. And the first step in that was to look at a technique known as transcranial direct current stimulation, which is a slightly different neuromodulation technique, still within the umbrella of brain stimulation. But TDCS, transcranial direct current stimulation, actually has a very long history dating back to the 1700s, as you can see with Luigi Galvani and Alessandro Volta. So we have galvanization and voltage from their surnames, first showing that muscle in particular was stimulated through electricity and not as a fluid or a humour, as they called it at the time. And so this really revolutionised the understanding of the nervous system, but also the muscular system at that time, but particularly the nervous system. And so the earliest mentions of stimulation from Galvani and Volta were through stimulating a muscle, but Giovanni Aldini was able to actually take this and use it to stimulate brains. And so what he found, quite accidentally, is that when his patients, depression patients or his patients with mental illness were receiving electrical stimulation, he found that their mood and melancholia had actually improved. So there was a hint that electrical stimulation may be able to modulate the brain, but at the time they didn't really understand how that happened and why that happened. But it wasn't until another couple of hundred years, until the 1960s, that DJ Albert was able to show that there was brain activity changes with the arrangement of electrodes in animal models. But what he found was that with particular patterns of placement of the electrodes over the head, there could be increase in or facilitation of brain activity, as opposed to depression as well. So this gave us a hint about how the brain could be modulated. The modern version of brain stimulation using electrical stimulation is known as TDCS, and as you can see here, it's a very simple setup and not really much different from the 1700s. So what you have is a small battery-driven electrical capacitor. You have two electrodes. One is increasing in excitability or anodal, and one is decreasing in excitability or cathodal. And you have the flow of electricity from the anode to the cathode. And so, as you can see here in the slide, if you have a anodal arrangement where the brain is, the area of the brain here is receiving the anodal electrode, this area of the brain will increase in excitability. If you flip it, this part of the brain will have increase in excitability, the frontal area, whereas the cathodal area will actually become depressed. So it really depends on how you arrange these electrodes. But TDCS is actually quite mild. You may or may not feel a little tingle above the scalp, and it doesn't actually change the activity of the neurons underneath, but rather what it does is that it changes their threshold to fire. So it makes it easier to fire, or in the case of cathodal, more difficult for them to fire. So it's very important to understand the arrangement, because this can influence changes in behaviour and mood, depending on how you establish the electrodes. But before I move on to transcranial magnetic stimulation, one of the things that came out of the case study was that despite this initial improvement, over time that we continued the TDCS treatment, we actually found Faye had expressed that her symptoms had actually started to return, and so by 2 months, 3 months, she was almost back to where she was at the start. So what it was telling us was that TDCS, whilst probably having an initial positive outcome, really wasn't a strong enough stimulus in terms of altering or modulating the brain tissue underneath. So for us, it was a good lesson learned that we probably would need a technique that is a little bit more robust and has a little bit more effect on the underlying brain tissue. So this brings us to transcranial magnetic stimulation. And so transcranial magnetic stimulation is actually an extension of the electrical stimulation, TDCS, and also transcranial electrical stimulation. And so it took about 20 years to develop the technique following the work from the 1960s, where Merton and Morton were able to show that if you applied transcranial electrical stimulation, which is a lot more powerful than TDCS, you can actually influence the firing of the underlying neural tissue. So for them, they placed it over the motor area of the brain, and they were able to show twitches in the muscle. And so this showed us that it had a much more direct effect on the underlying tissue as opposed to TDCS. However, TES is actually quite painful, and really it was always going to be difficult to sell it as a potential diagnostic or even as a diagnostic tool. So 5 years later, Barker et al. From Sheffield University were able to extend on this work from Merton and Morton and illustrate using a magnetic field that you can actually get the same effect without any associated pain over the scalp. And so this leap forward in terms of magnetic stimulation as opposed to electrical stimulation really opened up the area of research for both diagnostics and for therapy, particularly when repetitive TMS was the next phase after the single pulse TMS, which you can see there as the picture shows from 1985. So the mechanism of TMS, it does differ. As you can see here with the diagrammatic, we place a copper coil that is attached to the electrical capacitor. It feeds the electrical pulse through the copper coils, creating a magnetic field. This magnetic field can actually depolarize or stimulate neural tissue. So when you place it over the scalp, it creates a stimulus within the brain tissue underneath. And this is the big difference between TMS and TDCS. And so this stimulus can be recorded using electrodes over a target muscle, if we place it over the motor area of the brain, and we can actually get a response. And this illustrates that we actually are stimulating neural tissue. So single pulse has got a very good diagnostic capacity. It allows us to see the integrity of the brain tissue at the time of stimulation, and it's a very good accessory tool to other techniques such as MRI, and indeed many neurological studies will use both techniques to look at not just the structure but also the function of the nervous system. So with the extension of single pulse TMS to a repetitive TMS, where you have trains of pulses at certain frequencies, this can actually be placed over different parts of the brain, and through the principle of functional connectivity, if you are stimulating particularly in the frontal area of the brain, you can actually get changes in activity in other parts of the brain as well. So repetitive TMS or RTMS really has some fantastic potential in terms of changing the excitability of the brain, modulating the brain, and even potentially creating neuroplastic effects that may change behaviour and symptom alterations. And so RTMS is being used quite extensively in the psychological or psychiatric space with depression, but there are a number of extensions on this into experimental neurology. So the technique is now being used for conditions such as epilepsy, motor neuron disease, Parkinson's disease, and also MdDs. So what we need to understand now is can it be used effectively, and if so, how do we go about it? So this is the technique here. So I'll just illustrate here with a short video with Faye receiving the TMS. So as you can see, I placed the magnetic coil over Faye's frontal lobe, over the left frontal lobe, and you'll hear hopefully a train of pulses, and these are going at 10 hertz or 10 pulses per second.
Just let us know how it feels. There might be a little tingling of hitting some nerves. All right, and just staying nice and relaxed. Here we go. How was that?
Yeah, no, that's fine. Just got a little bit of tingling down my nose.
Okay, so you can see Faye's quite comfortable with the technique. RTMS, repetitive TMS, is non-invasive. It is very safe. Doesn't people can come in, get their treatment, and then basically walk out of the clinic or the lab and get in their car and drive. So it really just has it's not the same as ECT, for example, which is much more invasive. Most of the time, Faye and I would be talking quite casually while doing the stimulation, so it doesn't inhibit her capacity to talk or to converse or to think about things. And so what we would do with Faye is we would do 20 minutes of 10 hertz pulses of 20 pulses for 100 sets, so it came up to about 2,000 pulses per session, and we did this twice per week. And this was actually coming on from the study from UNHCR. By this stage it had actually been published. So we were actually replicating her study and her protocol. And so this allowed me then to extend on UNHCR's initial study, which was just really looking at one bout of RTMS. For me, it was to look at the initial success from UNI's preliminary work and apply it in a more clinical context of repeated sessions. So we were able to do this over 4 weeks, 8 sessions over 4 weeks. So we had 14 participants who were able to meet the inclusion criteria for MdDs and also getting a diagnosis of MdDs and referral from their medical practitioner. As I said, we did follow the UniCHAR study, placing it over the dorsal lateral prefrontal cortex. And we had 2 groups, so we had 7 and 7. One group had the real treatment, and the other group had a placebo treatment where we had the coil, exact replica of a coil that could deliver the same sound, the same feeling, but just a percussion movement within the actual casing itself. So people didn't know whether they got the real stimulation or they got a placebo bout. And so we did 8 20-minute sessions twice per week for 4 weeks. And same as before for phase case study, we were limited to using a balance test and also the activities, confidence of activities of daily living with their balance as well. So, and we did that pre and post treatment. The ABC we did pre at 2 weeks and post. So as you can see here with the balance testing, we have the placebo group in the dotted line, and we have the real treatment in the solid line. If you look at, there were individual variations in terms of how they responded with their balance testing, but you can see that with their balance testing, they didn't change really in group scores out of a maximum of 30. Again, a 3-point change out of 30 really wasn't clinically significant, and we're also seeing ceiling effects occur. So again, limited by the type of test that we did. What we found with the activities of daily living as well with the balance, we actually could see that there was a significant increase at the 2-week mark between the 2 groups. So the score for the real TMS treatment went from 45 to 57, but within that you can actually still see some variation at that 2-week mark. The sham group, the placebo group, didn't actually change. They were for a group average of 45, then changed to 46. By the 4-week mark, there really wasn't any change in both groups if we take the 2-week mark to the 4-week mark. So with the real TMS, their score was 57 at the 2-week mark and went to 59 by the 4-week mark. So again, no real change. And the sham group remained at 46 and went to 48. So it seemed to be a very short-term improvement, and then it's kind of leveled off. So I'll discuss that in a moment. So what it tells us is that RTMS does have some potential in modulating the brain and looking at symptom reduction. Anecdotally, we found that the group that had the real treatment were discussing their reduction in symptoms, but also it's showing an improvement in that ABC scale. Interestingly, we had one of the people from the sham group actually pull out due to uncomfortableness of the RTMS, and that is something that we need to acknowledge, is that RTMS may not be for everyone, because despite the fact that it's non-invasive, some people do find having the scalp stimulated not a very nice experience, and so we do need to make aware that this is a technique that may not be suitable to everyone. And 2 of the participants in the real group also experienced some mild headaches during the sessions as well. So which actually stopped after they finished the session and took a Panadol as well. So for us, it's something that we need to consider. the initial data from this study does seem to support the work by Yoonhee Cha. We do need to continue on from this because we do need to understand that maybe a one-fit-all approach in terms of the stimulation intensity, the stimulation frequency may not work for everyone. And so we may need to look at it in an individualized approach towards this, but this requires obviously a lot more research to understand that. And we also need to take in some other measures as well, so for example fatigue, mood changes, cognitive changes. We need to look at a better way of teasing out the improvement in symptom resolution. So there's a lot more work that needs to go ahead. But we do have some preliminary evidence that suggests that we need to hopefully look at this. So as I said, further research is required. We can move forward in terms of using this technique. At this stage, it's a case of getting some resource together, getting some funding to look at further research. We also probably will look at trying to improve the inclusion and exclusion criteria as well. So there were a lot of good lessons learned from those two studies, with the case study and the preliminary RTMS study. So I really do thank you for allowing me to speak to you at MdDs Australia Conference, and I really look forward to presenting again at your next conference and have some positive news. Thank you very much.
There's always hope. You should never give up hope. If you give up hope, you might as well not be on this earth.